Hello and welcome to Track 2, the Legislative and Medical Advocacy. My name is Christian, and I am excited to be hosting for this morning's breakout session 2. As a reminder, this track is being live streamed, and I would like to welcome our remote attendees and remind everyone that it's not too late to download our mobile app and use some of the highlighted features like the live Q&A. This session is all about how to approach your state and advocate on a different level with development of rare disease advocacy councils. Speaking on this topic, I would like to welcome Tara Britt, Associate Chair for the North Carolina Rare Disease Advocacy Council and Rare Disease Institute, and Sharon King, President of Tailors, TAIL.
Thank you. Thank you, Christian, and we want to thank Global Genes for inviting us here to speak today. We were really thrilled to get this opportunity. So today, we chose to not stand behind the podium. We want to sit here, and we're basically going to tell a story. And this is very informal. Sharon and I, we're not really scripted with any of this at all. And we are going to save questions until, well, actually, if you feel like this is really informal, so if people have questions during this, I'm fine. We're fine with the interruptions with that. That's good with us. So, like I said, we're going to tell a story today about how we were the first state in the nation to create a rare disease advisory council, and our story is going to talk about not just creating the council, but expanding this to a whole rare disease network in North Carolina. And I want to turn this over to my colleague Sharon King because she's the reason that we are sitting here today. So, Sharon.
Thank you, Tara. When my daughter Taylor was diagnosed with infantile Batten disease in 2006, I have to admit I really hadn't thought much about rare disease, but I thought about it a lot once Taylor was diagnosed. And within several months, Taylor's Tale was founded for several goals. We first of all wanted to support research. We wanted, as most parents do when they start foundations, wanted to find a treatment. We wanted to find a treatment for Taylor. We wanted to help move forward advocacy, both at the federal and the state level, and we wanted to, of course, expand awareness. So with family and friends, we founded Tailor's Tale and in an effort to fight back. And we learned pretty quickly that lots of other people weren't thinking about rare disease either. So in 2013, with a group of international funders, we started working on a project at UNC in the UNC Gene Therapy Center. And in working with that project, first of all, we were in Charlotte, so we were about 3 hours away, and it was exciting to be so close to Chapel Hill. And we developed a strong relationship, a real bond with Dr. Gray, with Dr. Stephen Gray in his lab, and other folks at the Gene Therapy Center at UNC. And through that bond, there were lots of interesting opportunities that were revealed for state advocacy. I grew up in the Research Triangle area. Was born and raised in Raleigh, and about the time the Research Triangle was really kicking off, I was a child. So I knew what existed in the Triangle. It's home to many, to high tech, to life sciences. There's lots of industry in the Research Triangle Park. There are 3 universities, UNC, Duke, and NC State, that help form that triangle of technology and research and academics. And so we knew from the development of the Research Triangle about this, the level of innovation that is happening in that area. We knew about the industry that's based in the area. And from Tailor's Tales perspective, we thought there might be one thing that could be enhanced, and that was that mechanism for collaboration. You know, when you're a rare patient or the family of a child with a rare disease, time is everything. Patients with rare disease just don't have time to wait. So you're always thinking about how fast can we get this done? How efficient can it be? How effective can we be? And we realized that if we're all working together and moving in the same direction with the same goals, we're going to be faster. So I think that was part of the stimulation for talking about and thinking about being activist at the state level. So in January, in fact, January 2nd of 2015, I met with Representative Becky Carney, who isn't my district representative, but I knew her from working on volunteer efforts years earlier in Charlotte. And so I asked her to meet me for breakfast. And we talked about, you know, my perspective of what was happening in the rare disease communities in North Carolina, talked about opportunities that might, that could be addressed for rare disease patients, families, and others in North Carolina. And Representative Carney was interested. And she was, tell me more. You know, how can I help with this? What can we do? So she agreed to be the legislative sponsor for a breakfast, a legislative breakfast. We first scheduled it for February, but of course it snowed, and you know, an inch of snow shuts everything down in North Carolina. So we were rescheduled for late March. Well, if we were going to get any legislation filed, we were already a little nervous that we were going to be on the outside with the timing. But we went for the late March breakfast. And I remember going to the legislative building and seeing the place that had been suggested for the breakfast. It's actually the cafeteria that is in the underground parking garage of the legislative building. And I remember the afternoon before we went to set up, and I looked at a Tailors Tale board member and said, no one is going to show. We are going to be having a breakfast for us. I couldn't have been more wrong. We had a really good turnout. We had legislators, staffers, we had patient advocates, we had our friends and supporters from our UNC family. It was really a wonderful turnout. And driving home that afternoon, Representative Carney called and said, there's a buzz going on. You've really, you have their attention. So the legislation was filed a few weeks later, just before mid-April. And we couldn't believe how quickly things moved. Every floor vote, every committee vote, it was unanimous. We were totally supported. And I learned a few lessons about moving things forward in the legislature. Don't make assumptions about your legislature. Do you think they'll be supportive or not? I remember there was one particular legislator that I never visited him. And all that time, Tara and I spent a lot of time on the phone, making personal visits to share our case. Why was it important that we have a rare disease council in North Carolina? And there was one legislator that I just really never found the time to visit. He ended up being one of our most staunch supporters. In fact, the very last floor vote, very unexpectedly, he stood up and very eloquently talked about the reason this council was a good thing for North Carolina. And we found out he actually had a child with a rare disease. So don't make assumptions. When you're talking with your legislators, don't make assumptions about their interest. Make sure you get to everybody. You never know who your best supporter can be. But bill was filed mid-April, Governor signed it into law early August. So within 4 months' time, we had a North Carolina Rare Disease Advisory Council. You know, what were the things that helped us make this happen? From my point of view, first of all, and Tara's going to talk a little more about our champions, we had secret weapons. We had champions who walked with us every step of the way. If we hit a hurdle, our champions were there to help us clear them. So if you want to do this in your state, I tell you, the first thing you've got to do is identify those people who can be your champion as you're going after this council. You're going to need it. The other thing we learned, this is not party. Rare diseases are not discriminatory based on party. You can be Democrat, Republican, Independent. Rare diseases don't choose. So everybody is your friend at the legislature, and they need to hear about what rare disease patients face. One of the things that we made very clear to the legislators, both at the breakfast and throughout our efforts to make the case, if statistics hold true with 1 in 10 Americans having a rare disease, that means that there are 1 million rare disease patients alone in North Carolina. And then there's a trickle-down effect. There are, these 1 million patients have family, they have loved ones, they have people that care about them. And so exponentially, we're getting greater numbers. So we made it very clear that rare disease patients and everyone that cares for them are their constituents. And they have to care about these people. And it really made a difference when they started thinking, oh, the numbers, this is huge. Rare is not so rare.
So talking about that and working at the legislature that summer was quite challenging. And I remember one of the main sponsors of our bill, Senator Lewis Pate. And I remember stalking him, making sure, because he carried a lot of power. And my friend Rufus Edmondson, who is one of our secret weapons, was former Attorney General and Secretary of State. And he was very well respected bipartisanly. And he'd call me at 7:15 in the morning. He says, now, honey, remember, we're in North Carolina. Honey, you need to get down to that legislature, and you just need to wait at his office till he gets there, and you talk to him about this rare disease and this council and how important it is. And I remember Senator Pate saying, why should I put my name with this? Why should I support it? And I looked at him directly and just pointed at him, and I said, because 1 million of your constituents have a rare disease. That's why. It makes up more than HIV and cancer combined. That's another reason. Do you need any other reasons? He said, nope, that pretty much did it. I'll support your legislation.
Yeah. So all in all, you have to be able to make a clear case for why this legislation is so important. And we worked hard to make that happen.
Okay. So now we have the legislation. What happens next? This is where we had to be very, very careful on who was selected to participate and be on the council. Initially, the council was comprised of a much larger group. And they came back, because I was housed in the School of Medicine and co-wrote the legislation. Dean Roper, our dean of the medical school, was kind enough to house the legislation there so I could continue my work with the council. So we had many more people on the council to begin with, and then they kept sending it back to me, and I said, finally I got the last draft. I said, I will only do it if we have at least this much representation. We can't do it with less than this, because it was like setting you up to fail. You had to have key players, and you had to have enough of those. So we felt good with this. So we have clinicians, one from Duke, one from UNC, who are in the rare disease community, or rare disease clinicians. We have patient advocate, which is Sharon King. We have a rare disease survivor, which is Rufus Edmondson, who helped us get this legislation through. He took this very personally because he is a survivor of Guillain-Barré. So this was very dear to him, this council, and creating it. He remembers being in the hospital, not knowing if he would ever go home. So he is truly one of our secret weapons. And then we also have a nurse. She's a hemophilia nurse that's represented on there. The day that I knew the legislation was going to go through, I thought, who should chair this council? Who would be the perfect person? And I happened to be working with Dr. Bruce Cairns, who's an MD, and he's over the North Carolina J.C. Burns Center. And he does deal with some with rare diseases. But I thought it was very important that this council focused on rare diseases as a whole and people didn't come in with their own agendas. That was very important. So I called him. I'm outside standing at the legislature. I said, it looks like this bill is going to go through. Would you chair this council? And he says, well, I'm really busy with this. I said, no worries. He said, if you'll do the legwork and do the day-to-day, I will be glad to chair the council because I'm very interested in making this happen. I said, great, because your name's already on it. And I said, done deal. I just wanted to go. So we had that. And we have a researcher, Dr. Arvind Asokan, who's at UNC in gene therapy. He is also on it. And so we put together a council of people who, yes, they came at it from their own individual, whether they did research or clinicians in their specific diseases. But this council really came together. Our first meeting, we talked, and I want to mention the Deputy Secretary of DHHS is also on the council. So we came together and nobody had their own specific agendas. And we really formed a council that we knew we wanted to progress, the rare disease network. We wanted to get back, but our job was to get back to the governor, to the General Assembly, to the Secretary of DHHS. What are the issues surrounding rare disease patients, their families, the research? Get back and tell us what are these issues so that we can address them in the state of North Carolina. So we did that, and we have council meetings quarterly. We have, not just the council attends these council meetings, so many people in North Carolina with the universities, in the biotech, pharma. We have people, our rooms, we have no more room. We're actually moving to a different conference room for the next time. It's standing room only with these council meetings. Everybody has a voice, not just the council. Everybody, we have a clinician who's very passionate about newborn screening, and she's been coming to the meetings, and we're trying to get some newborn screening bills passed. And Erin's shaking her head, she understands that in North Carolina. So we have people that are passionate with rare disease issues who attend these meetings, and we listen very carefully to what they say. And so because the council is politically appointed, we do have to be careful about what we can advocate for in terms of certain bills or certain legislation. So we decided a way around that. So we just recently formed a task force. This task force is made up of patient advocates. So they come and they present to the council. They take a topic. The first one is going to be newborn screening that they're going to address. And they put together, this task force isn't going to be the same for each concern. It depends on the topic of rare disease. That way the head of the task force will decide who are the best subject matter experts to be on that specific task force to make recommendations to the council. So that was our way of kind of like, bypassing the political, exactly. So, okay. So the council developed a plan to learn more about the rare disease community, and I'll talk a little bit more about that. And we wanted to make sure that everybody knew that this council and the activities of this council and the network were always patient-centric. There were no other agendas except what would advance the patient's needs and the patient advocate's needs. When Sharon and I would go out, it was never just, we were a team. We were a tag team, actually. They had nowhere to run. Because, I'm being really serious, so if somebody was trying to avoid us at the legislature, I might go one way and she's going the next. I said, if he tries to, not listen to this crazy woman stalking him about the council, anyway, to get the needs through, and then Sharon would pick up where I would leave off. So what we did, we started going out, and I needed to know more about rare diseases in North Carolina. We didn't really know that much. And so we talked about what we were doing with the council. We went to visit Chris Austin and all of his directors for about 4 hours one day in D.C. They were very gracious and give us feedback, and Chris was so funny. He said, so wait a minute, you're really saying that UNC and Duke are collaborating? He said, is it just on a piece of paper? I said, no, I'm over at Duke just as much as I am at UNC. We have UNC clinicians and researchers coming over to Duke, coming over to UNC, and vice versa. He said, wow. He said, that's a good start. We were building collaborations because what we had found is, seems like, and any of you in academics know, people work in silos. So we had people, even within UNC, working on common rare diseases that didn't know one was working with the other. I mean, they just didn't know. So that was part of what we knew we needed to build. We had several meetings with Senator Burr. Luckily, our friend Rufus Edmonston, one of our secret weapons, was good friends with Senator Burr. And so from the start of this, he has been very supportive. We've met with him 4 different times. And when I say we, I want to make sure you all realize it's not just me or the chair of the council meeting or Rufus. Sharon is always at the table, or a patient advocate is always at the table, because it was like when we met with Congressman Butterfield, this is why we are here. She's why we are here. Taylor is why we were sitting here, and all of the other Taylors in North Carolina, so that they know what we go forward with is definitely about the patient and the patient advocates. And Congressman Butterfield, we were delighted to hear, became a congressional co-chair of the Rare Disease Caucus. So we connected with him, had a long meeting with him, and we told him he represents districts that are very urban and rural. I don't know why I said urban. Rural. So we said, our concern with the rural areas are people that don't have access to internet. They're not close to a Duke or a UNC. The poor areas. What are these families doing? And maybe you want to talk a little bit about that in terms of patient advocacy in the rural areas and what we have access to.
When we met with Congressman Butterfield, I thought it interesting that he kept bringing up what was happening with constituents in the more rural areas. And interestingly, I was able to share with him, we talked a lot about diagnosis. He had a big interest in diagnosis. And I was able to share with him that there had been several children diagnosed with forms of Batten disease in North Carolina in recent months before we met with him. And 2 of them have the same form of Batten as my daughter. And we were talking about age of diagnosis, and a child in a rural county was not diagnosed until age of 12, whereas a child in a more urban area was diagnosed at the age of 6. Same disease, same form of Batten disease. And so we were able to give him really strong examples of why we needed to make more. We needed to build these networks and things that are going to help us get more into these rural communities that just don't have the same access.
So, let's go to the next slide. Oh, that's not the next slide. Okay, so with that being said, we knew we needed to develop a rare disease network in North Carolina, one that extended past the council, that's not just RTP-centric, that goes into every area of North Carolina. And so this is our journey with that. Okay, so building the network, I'm going to talk a little bit more about our joint forces and our secret weapons. This picture was taken on a Rare Disease Day event at the legislature. And no, it was not held in February or March. It was held June the 7th. And the title of the event was Rare Disease Day is Every Day, because those living with rare disease is not just one day a year, it is every day. And that was our reason for having that. We had 135 people register for the event. We had large pharma companies to come out. We had patient advocates from all over North Carolina to come out. And we took a whole courtyard and we talked to the legislators. We had support networks to come out. One of the ladies in this picture is Christy Schaefer. She comes from a biotech industry and she's now a partner with Hatteras Ventures. Since the inception of this council and the network, she's been there as just a trusted advisor to say, hey, do you know the CEO of this pharma company? Hey, do you know this? Let me make introductions to you so that you can get in and you get the feedback you need to find out what needs to happen in North Carolina with rare disease. She's one of our favorite secret weapons. We have a man named Dr. Charles Hamner. Dr. Hamner founded biotech in North Carolina. He's one of the godfathers of biotech. Dr. Hamner, I worked with him 8 years ago. He came on board, worked with me every week for a year. Hey, let me introduce you here. Hey, I'll take you over to meet with these people. These are people that are doing this for no personal interest at all except to advance the causes for rare diseases in North Carolina. And it also had an economic impact to North Carolina, we thought, why are we losing so many of our good researchers and clinicians? Why are they leaving and going to Boston when we've got this great North Carolina RTP area? North Carolina is a great state to live in. What can we do to keep some of the talent local? And so he was very interested in that as well. So that was one of the things we looked at. So we basically built a team of people that just had the best interest for North Carolina to accomplish this at heart. Okay, next slide. Okay, so building this network for a year and a half to 2 years, all I did every day was just go out all through North Carolina, DC, wherever I could, to talk to key opinion leaders with rare diseases. And like I said, it was people with like Christy Schaefer and Dr. Charles Hamner and many others who were introducing us to people within the state who could make a difference with this, whether they were a legislator or whether they were a CEO of a pharma company. We talked to everybody. We went out for that long and talked to everybody. Academics, clinicians, and researchers. It was amazing just to hear their frustration with the system with rare disease. I talked to a hemonc transplant surgeon and his frustration with the system. And he introduced me to a patient advocate, Julia Fisher, who had 2 children to die under the age of 3 of undiagnosed diseases. And she told a story about being in the hospital bed with her son. And she had one hand on her son, and she has one hand fighting with the insurance companies. And I can't, that's a visual, that doesn't leave your mind. And so getting feedback from that, we also talked to social workers at UNC. I talked to social workers at Duke, UNC, their frustrations with the system. So we started building and getting a whole lot of feedback and, building a database of basically of concerns and what the frustrations were across the state of North Carolina from all these various groups. Okay. One of the largest problems I noticed when I was talking to everybody, data. So, okay, I didn't know that much about rare disease coming into this. I was working with Sharon and Dr. Stephen Gray. That's how I got involved. And I thought, surely, okay, what I'd like to see, what hits Medicaid by rare disease? I didn't need any HIPAA-related information. What hits Medicaid in North Carolina by rare disease? So I want to see that. I talked to the Deputy Secretary of DHHS. He said, sure. Talk to our CIO. I talked to the CIO. He said, there's no possible way to get that. There's no true diagnosis codes. You can't pull this out of the medical records that easily. It's just not done. I go to NIH, talk to their heads of the translational pieces. We don't have that information. Talk to some guys at Harvard. Yeah, we should be able to get that, but it's just not available that way. So I thought, we've got to be able to get this type of data and other data. Pharma wanted to see about 6 sets of data, none HIPAA related. They wanted to see where patients lived, what is the social economic impact. There were certain data that they wanted. Clinicians wanted data. We thought, how great, thinking about these clinicians in rural areas who the diagnosis time takes so much longer because they're not familiar with rare diseases. I said, could we build a system in North Carolina of everybody that's affiliated with rare diseases and then maybe have a database that took data analytics and took symptomatic codes that could help tell what clinical trials were doing, who was doing research, and that came up with diseases of possibilities it could be that they could contact. So we had data sets, several data sets that we came up with what we wanted to see. And then one day, in regards to data, I saw on my email an announcement come across from National Science Foundation. I normally didn't pay attention to NSF. And it said, building big data observatories. I thought, looked at it. And it was a RENCI hub, which is Renaissance Computing Initiative. And they said, I found out there's a southeastern hub, southern hub. Hey, that's located in Chapel Hill. I contacted the 2 guys that ran that. And I thought, we would need to build a big rare disease observatory where we build a portal that patients can log into to get information, that we can combine registries up under one umbrella, that clinicians can log into to get information, various types of logins for this huge portal. It would be great, all rare disease in North Carolina, all open source. So I went to talk to those 2 gentlemen the day before Thanksgiving, 2 years ago. They said, we think this is a great idea. We're all about this. Who are you going to partner with? I said, well, I was at NC State for 25 years, and I worked with computer science and electrical engineering. I'm going to partner with NC State. I called my friend, who's vice chancellor at NC State. I said, former computer science chair. I said, give me somebody to work with. Are you interested in doing this? Went to meet with him. this falls right in line. We'd love to. It brings data analytics in healthcare. We wrote a planning grant, and it was funny because everybody at UNC said, you're never going to get this. This is not going to happen. We got it. So we got the planning grant to explore the possibilities of data analytics and how that relates to rare disease. So we got the planning grant, and now just recently, with another secret weapon I'll have to tell you is this man at NC State. He is a former, helped develop IBM Watson, because I first approached him and said, just give me a Watson. Just give us Watson. He said, oh no, I developed Watson. We're going to blow that out of the water. And he doesn't stop. And mind you, none of these people, there's nobody getting paid for this. These are people wanting this to happen. I want to make that very clear. NC State wasn't making any money, wasn't getting anything for this. So we got the planning grant, working with him. This led to other opportunities and grants, and we bring in the School of Pharmacy with drug discovery from UNC. We just received a North Carolina General Administration grant for $2 million to help build these data analytics. We are now going for a $1 million grant at NSF to continue our planning grant. So we have a lot of excitement and buzz, and I just love when people that told us that this wasn't going to happen to make sure that they see the awards that we're getting with this. It's just such a great such a great feeling. So luckily these secret weapons at NC State also, because we are in RTP, they work with IBM and SAS. I said, hey, let's show a little love. How about some data philanthropy? Come on, SAS, IBM, throw us some of your folks. We are now working with that. If you don't want to give back in a financial means, give back with data philanthropy. So now we're engaged also with IBM and with SAS through this. It's been amazing, to be honest. I would call Sharon and I laugh about this all the time. I'd go out throughout North Carolina, talk to somebody, and I'd call Sharon. I'd say, Sharon, it's been the best day today. You're not going to believe who I met with. This is going to change. It's going to change the world. And she'd say, well, didn't she call me the next day? And she'd say the same thing. So this was just so many key people wanting the same thing to happen, just for the purest of reasons. Okay, so this leads to the next step. We knew the council could do so much, and the council, let me remind you, is policy. We're policy, we're legislative. We realized very early on, Sharon and I did, that we're going to have to create a nonprofit to help support the initiatives in the state of North Carolina if we wanted this to succeed. Therefore, with the help of Senator Burr, we created the North Carolina Rare Disease Innovations Institute, NCRDII. We just got our nonprofit status just a few months ago. We're now developing social media, the website. The people that are building the website and doing the social, these are people volunteering. We don't have any money. These are people just wanting this to happen. So what we did initially, let me tell you, we have the other secret weapons. Charles Hamner decided that he would love to come on board with this as Chief Scientific Officer and Chair of the Board. And it doesn't hurt to have the person that founded biotech serving in those roles on this. It carries a lot of clout. And then one of the guys that I knew from the Hamner Institute when Charles had that was a guy named Rick Williams, who was one of the founders of Genentech. He's been a CEO all over the world. He's traveled from here and had businesses in China as well. And he was in the rare disease area. He said, he emailed me one Thursday, and I knew the whole time that I wanted him. He was the only one that could really fill this role. He emailed one Thursday, and he was coming back from his stint in Boston where he was working with organs on a chip, and he had taken that to the next level, and he was ready for something else. He emailed Charles and I, and he said, coming back to North Carolina on Thursday. I said, emailed him back, do you have 4 hours to meet with me on Friday night? And that Friday night, I talked with him, and it was interesting because he kind of interviewed me as well and said, why are you doing this? Because we decided early on we only wanted to do the right things for the right reasons, and the people had to have only the purest of intentions with this. And so he came on as CEO. Again, we're about to hit fundraising stage, so we've not done that. And then our other secret weapon, Christy Schaefer, came back in, and she said, you know, this has been tried about 10 times in North Carolina, but it's never had the model that we set one up that is patient-driven, patient-centric. And it was funny because we were in an event. She comes, and they said, well, why do you think this will work? It's been tried so many times. She said, because these people have the drive to make this work, and they're doing it the right way. It's all about the patients and the patients' families and the advocacy. So we were very lucky with that. So she helped as well establishing this nonprofit. And then Rick decided, hey, we need to really branch out and go all throughout North Carolina to develop this network. So we initially started the RTP, Rare Disease Community Network. We had that in place. We had our partners in place. We knew it would work. So Rick says, let's go to Eastern North Carolina next. So we decided that we would go to Eastern North Carolina, and I'll tell you a little bit more about that in just a minute. And then facilitating new research collaborations, like I said, we talked about the grants, and then the power of data analytics with Watson. All right, let me go to this next one that's really good. I'm sorry, hold on a minute. Okay, so here's creating this. So before we get into this, talking about the Eastern North Carolina, Rick and I were brainstorming for about 4 hours, long lunch meeting one day, and he said, we'll go to Eastern North Carolina because that's where the School of Medicine, East Carolina's Brody School of Medicine is. So we'll go there. And I said, well, wait a minute. Senator Pate was one of our champions of our legislation. Why don't we partner with the legislators and go to, a lot of their districts where we hit in these areas in North Carolina, have them partner with us? Because that shows, hey, look what we are doing with what with the council. I will say they did earmark money for the council this year. It was only $100,000, but at least it was a little pot to help keep this going, for the state. So anyway, we decided to do that, and I called the secret weapon Rufus Edmiston, who goes out once a month with several politicians, and they go to a steakhouse in Wilson, and he had Congressman Walter Jones with him, and he had Senator Pate. And I said, would you talk to them about this and say, look, we want to go to that district in Greenville, and would they like to participate, or would they like to help put this together? Not only was Senator Pate so thrilled about this, he said, I will host it. I know the conference room we can go. I will get the players. They were so excited. So this not only just talks about, hey, we're going to go meet with the other clinicians and researchers. Sharon will be going to try to put patient advocacy groups together. Hey, look what we're doing in North Carolina for patient advocacy, building her database for patient advocates, so that when we send out any emails, we cover everybody, the people in all the different parts of the state. And then we decided to map out all these other different areas in North Carolina. So we're going to start out with East Carolina, and as soon as I get back Monday, that will be what I work with Senator Pate on, and start with that. So, as I said, we're going to go through and start building our networks with that, and really truly having not just an RTB network, but a statewide network. Okay, so with the Innovations Institute, it's all about creating new patient solutions. And if you see this is what the CEO, Rick, put together. You always have the patients and their families in the center. And then we're also working with the next generation computing, like I mentioned at state, and then we have the UNC and Duke Medical Network right now. And then we have government and industry. And then I'm going to turn this over to Sharon to talk about what we are doing so far with the Innovations Institute for patients and their families.
For patients specifically. So Rick has described the patient portion of NCRD2 as, and I quote, dedicated to increasing support and easing the burden of families and patients managing a rare disease. So we knew we needed to collect information from patients and families. So one of the first things we're going to do is we're developing a portal through this data system dedicated to patients and patient advocates. And we're going to use this information that we gather from this to develop quantitative models that illustrate the overall cost, both in time and in effort, that is required to care for rare disease patients. And the hope is that by using the models that can be developed from the information that we're gathering, that we can help persuade government, payers, medical groups, anyone involved in care and support of rare disease patients, that we can persuade them and improve access to support and care. So how are we going to do this? So we've been holding focus groups, meeting with patients and patient advocates, and we also have just released a first survey to patients. And there were some requirements in doing this survey. First of all, we felt like it needed to be mobile friendly. A lot of people don't even go to their laptops now. I know my daughter's caregiver said she never opens her laptop. Everything, paying bills, texting, it's all on her smartphone. So we knew it needed to be very mobile friendly. And The other thing we heard from the focus groups was, I'm doing so much trying to manage, from a parent's perspective, caring for my child, just keeping food on the table, getting to work every day. I don't have time for a lot of surveys and a lot of effort at this. So we realized that this survey needed to be 10 minutes or less. There will be multiple surveys as we start to build this portal, but we are in the process now of collecting the information we're going to need to do this well from our patients and our patient advocates.
Okay. Thanks. And I've just talked about this previously, but like I said, let me skip into who we are. The Advisory Council, I want to remind you, is more of a political, policy-driven council. Then we had the Rare Disease Coalition, which Sharon is chair of, which is patient advocacy groups. They're members of this coalition. And they participate in these focus groups. They come together. They'll be participating on the task force to make recommendations of what needs to be done with rare disease. And I want to get back to that a little bit. We've got some pending legislation now. And I'm not always real tactful. I'm trying to be a lot more tactful as I go to the legislature, but well, the night before, those that know me know that's really true. So the night before we were having our event, the Rare Disease Day is every day, I was taking talking points to Representative Carney and to Senator Pape. And Representative Carney was in her office. It was about 7:30 one night, and I said, can I just be blunt? I just want to be blunt, and you don't take it the wrong way. She said, absolutely. And I said, some recent legislation had come about that would have really severely impacted rare disease patients and their families. And there was an outcry, thousands and thousands of people that it not only affected that community, but people with development that were developing delayed. It would cause parents who now could care for their children in their home, those children would have to be institutionalized. It was horrific, and the outcry was very horrific. I said, so instead of you guys coming up with idiotic legislation that, and I did use those words, that negatively affects, that has this horrible outcry, could we somehow do something to that we could advise on that first? She said, sure, I agree with you, come up with some legislation that, that could advise us. So we've got pending legislation now that says if there's any legislation that comes through, the sponsor would, at the discretion of the sponsor, because we don't tell them what to do by any means, and they've been very supportive. We've had a very supportive legislature, that they would come to the advisory council to seek input on how this would affect the rare disease community. And basically, before the legislation is passed, we just decided to go ahead and do it anyway by forming this task force. So that gets back to the task force we formed. And then we have the Innovations Institute, which is basically, we've modeled it a lot like the CF model. So if we commercialize technologies, then money comes back in to go back out to the rare disease community in forms of royalties or equities for that as well. And we will be having pilot projects. We'll have an industry partners program on that. We are in the process now. I'm setting up an industry focus group for industry to tell us what they think, how they would like to participate, and how they would like to be associated with this. And then we will put together the industry partners program. And then, of course, wave the flag for NC State with their brilliant data analytics. I can't say enough about their partnership with this. And honestly, with academics, you depend on funding. So there was no funding for this at all with what they were doing. And they took a chance on us and went to their provost and chancellor and said, we think this is really important. Could you put money in to keep these people doing this until we can bring in money with grants? And that's what's happened. And so this is a slide that the CEO of the Institute prepared, which I think is pretty neat. You've got all these, you see on the left-hand side, you've got all these different resources. And then what we are in the process of building and coming together. Results, we built a North Carolina patient advocacy database across North Carolina. We're building collaborations between clinicians and researchers across the state, soliciting the feedback from rural to urban, mountains to the beach, and what are their challenges, and then basically how do we improve the life of our patients and their families. And then we take the recommendations back to the council and back to DHHS. Thank you very much. Oh yeah.
Anybody have questions? Okay.
That was really actually very inspiring that you guys have built all this. This is awesome. I'm curious to see, did you have any opposition to the initial legislation? I'm sure and I apologize if this is offensive, but the insurance industry wants to like smother you in your sleep. Because anytime patient advocates for rare disease unite, I think insurance companies think, okay, they're coming after us. But I'm just curious, and do you guys like endorse legislation, or it's all only to create legislation, or is it just to help with research? Or all of the above?
Okay. Insurance. So the way we did this legislation, I know this is going to be live streamed. I have to be careful. So it was very under the radar, very under the radar. So we kind of just were very quiet about it, except for working with the legislature on that. And we've not had any real dealings actually with insurance at this point. We will be, but not at this point because the recommendations, of course, will come back. And as far as what we do with, we really look at the council piece as just as the policy, that we will go back and make recommendations from the task force or the coalition from the rare disease community. So we see ourselves as the policy makers, if we want to change policy, state policy as an outcome of what the task force recommends, that's really the role of the council. Now, the nonprofit can have a little different role. That can, at some point we will have our own governmental affairs person that lobbies and for the rare disease community as a whole on behalf of that. So there's a lot of people, it's hard for them to understand, but we have the council that's the policy, the Rare Disease Innovations Institute are the implementers. And there's a small bit of overlap. Does that help? Thank you.
Thank you so much. This has been amazing. And I used to work in North Carolina. I was in the UNC Peds Genetics and Metabolism Clinic as a genetic counselor for about 5 years. And you've added to the reasons that I wish I still lived in North Carolina. It's just
Did you work with
what
Cindy
you've been doing.
Powell?
I did.
Cindy Powell's a big part. Yeah, we
Oh,
were working.
good, okay.
We were working so closely with her. She's great.
Good, I'm glad, because I think that probably will feed into some of the comments, because I'm noticing, all the work you're doing with the government and the legislature, and I was just curious as to your work with state agencies, because I'm thinking about the data that you're looking for, as well as your ability to access all of the different rural communities, and it made me think about the Department of Public Health and the state laboratory that's performing newborn screening and ensuring that you're connecting with the follow-up and the feedback for patients that are diagnosed with rare diseases via that newborn screening. And then also thinking about, I don't know if it exists now, but when I was there, the regional CTSAs that followed children with developmental disabilities and other learning issues, and just thinking about using that as a regional connection to identify additional patients and families that would be interested in your network.
We're working with all of the above. CTSA, we got involved with them early on after meeting with Chris Austin's group, and Cindy Powell is actually driving as the clinician with the newborn screening. It was interesting because everything's all political. So basically, with Cindy and Sharon and all of us being really passionate about newborn screening, that was really the main reason we just developed this task force, because we knew we needed a way to bring in the deputy secretary of DHS to let him know this. And Cindy and Sharon also, they've been working very close with our state lab director.
That's fantastic, because then it feeds into your economic argument too.
Absolutely.
When you think about all those individuals who are on medical foods and other needs that they have.
And also DHHS. So DHHS, we just talked with the CIO there, and we're doing data use agreements with them to be able to access their information. And then I'm scheduling a meeting actually this week with the School of Public Health to try to, because everything we're doing is open source. We're not doing anything that's not going to be open for every other state to be able to access what we're doing. We want to build this as a model for everyone else, and everyone else have the same access without having to duplicate it, put the money into it. Why do that? Look what we've done. It will all be open source.
Congratulations.
When we were working with legislators to get the bill passed, we actually I mean, one of our slogans was, this is a public health imperative. There are so many people affected by rare disease. It's a public health imperative, and you have to recognize it, and you have to do something to help these patients and families.
Thanks. So I'm a Philly girl through and through, but you're making me want to move to North Carolina. Yes, we did just get a rare disease council, which is great. So my question is, and for everyone else that's in other states, do all the states do it the way you do it, that it's all politically appointed for the council, and then you have these other things?
I think every state has been really different. I think our model is probably different. We've done it more independently, I guess.
Alabama did it, and I think their council is much larger than ours, has a lot more, many more patient representatives. And we started. I mean, when we filed the first bill, we had a biostatistician on there. We had many more patient representatives, but the legislature and our sponsors wanted to keep it lean and mean from the beginning and said, get the bill passed. You can always increase the size later. If you feel like you need additional expertise appointed to the council, get the council, and then we can make those appointments later as you see the need.
Okay. And then my second question is, do you all address the issues in terms of education and daily living challenges for rare disease families too?
You know, when we first started, when we actually held the breakfast, we did talk more about, you know, the collaborations, the partnerships to help, you know, those mechanisms to help make research and everything that goes along with it more efficient, more effective. But that doesn't mean that there wasn't a patient component to this with patient daily issues that patients face. But with this task force, what we faced was, I wear two hats. I'm an appointed member of the council. I'm also chair of the North Carolina Rare Disease Coalition. So, and the coalition represents the patient voice. When we put the leadership team together for the coalition, I made a choice to ask patient leaders from around the state, regionally, to serve as leaders on this team. So when we go in to do these regional networks, we already have a base. We have a leadership base from the patient community. But it has been difficult. You know, on a personal level, I'm very interested in newborn screening. But it also, it creates a lot of issues in dealing with the legislature because it's a big topic and a serious topic. So, so we created this task force, which is chaired by someone who's not an appointed member of the council. I serve as a liaison from the council to this task force. And the task force will prepare a brief. They'll do the background work for the legislature, the effects on the community, both short-term and long-term. They prepare a brief. They have no power. They present it to the council, who then decides to act on it with members of the General Assembly. And so in that way, we're handling those areas that can be a little more political and touchy.
The education piece you were talking about, actually, we were just writing up this in a grant yesterday. So the nonprofit is really going to have a huge educational arm. And right now what we're doing in terms of the council and the nonprofit, in these grants, we're writing up educational arms for this. So like, for example, yesterday we wrote up, it's funny you ask, because we wrote up part that's going in this new NSF grant. It's a whole educational component about doing grand rounds with rare diseases in the various schools of medicines. Residents say, we don't hear anything about this. And then, so doing the grand rounds, having symposiums at in the schools of medicine and the UNC Healthcare and Duke and the various ones across the state with rare disease. So we are going to implement an educational arm across the state. That's one reason we're going to the first visit's going to be to the Brody School of Medicine at ECU to talk about that. And then we would like to have those as webinars so that anybody could come in and see what we're doing on an educational basis with this.
Great, thanks. Thanks for all the great work.
Thanks.
What you guys have done is very inspiring, and I would just love to know if there's any way for you guys to package this up and put a bow on it and give it to those of us that live in other states, because it seems incredibly overwhelming with how much information you guys have shared with us, and it seems hard to start from scratch. And
Oh, we get, I've worked, and Sharon has too, I get calls every week about this, and we are talking about doing that, putting that together. I had, when I was working with Illinois, when they were drafting theirs, they said, why don't you just come to Illinois? And I said, oh, I'll be glad to come and help. And once we get this really moving, like with the regional networks, we will probably, I'm sure we'll put a package together that can be used for all the other states, because every state's going to be a little different, because every state doesn't have a RTP or that, but it doesn't matter. You can still do what we're doing in every state in a way that it would work best for that state.
I think you have to figure out what are the resources and the assets that are available in your state that you can work with to create that win-win. And then, I've said that so many times, the reason I think we were successful was we were able to create that feeling of win-win for both rare disease, for those of us advocates in the rare disease space, and for the state. I mean, everybody is a winner in this. And I think Tara and I both saw, I think even before the legislation was passed, we had this vision of, and there's another step. There's going to be this implementation piece. I mean, we talked nonprofit, and there were other members of the council going, what? we're still working on council. No, we're not ready for that. And we were already talking about phase 2. But I think you have to find out what your state's assets are, how you can build on that, and I think it's going to look different in every state, because all of our states have different resources and different assets. Just find out what you can pitch to create that win-win that was so, I think that was the reason we were successful.
yeah, I just think anything that I feel like you've learned so much along the way, that even like a basic, I don't even know how it potentially could be shared through the group of people that have come to this conference, for example, because we probably cover many states. Even a very high level, where to start, and here's just kind of the basic idea without having to write an entire book on that, which would take you guys, a long time to do. I think that would be really helpful, just to spark for me in Colorado to be like, where do I start? How do I even find what the assets are that we have in the state?
And we were lucky. I keep bringing up secret weapons. We keep saying that. We're not here because of just Sharon and I. I mean, we're the drivers, but it was the team. I mean, we got Dr. Steve Gray here in the audience. I mean, I wouldn't even be doing this if I wasn't working with him in the gene therapy area. So we had a lot of secret weapons. That's what we love to call. They love for us to call them the secret weapons as well. So, that championed us, and that's. I think we're unique, because I know with like Illinois, there's wanting developed under like a UNC or a Duke or what have you, and so it was just we do need to provide tips, because there's a lot of times, I know I especially had to be careful because I was a state employee at the time. You go under the radar, just fly under the radar, build this, kind of like build it, and then everybody jumps on board, but it's already been built, so you don't have a choice. You got to jump on board. You know what I'm saying? So yeah, that would.
They loved us before they knew they loved us.
Yeah. So I'm glad you mentioned that, and some other people have mentioned it too. So yeah, once we get to a place where we're not moving every day we would love to put something together. And anytime anybody can contact us, I get calls all the time. I am happy for anybody to contact me, and Sharon and I are always happy to get on a call with people together as well.
We're all in this together.
Thank you both so much. That was awesome. Thank you both so much. So that concludes our morning breakout, and I thank you all for joining us. Before we head out to enjoy our lunch, generously sponsored by Pfizer, if you can jump onto your mobile apps and take our brief survey from our session, we'd really appreciate it. And I would like one more last time here to thank our wonderful speakers for such a great session.